and share the latest and greatest in infertility with you. So thank you for joining us tonight. We always take a couple of minutes to let everyone jump on and get your tea or coffee. And I don't think you need popcorn, but sometimes it's pretty entertaining.
I think popcorn is a great idea.
It's a great idea. And and then we answer your questions. So if you have questions, just punch them onto whatever platform you're on, and we will definitely try and get to all your questions. The show has grown a lot lately, so the sooner you answer or ask your questions, the higher the chance it'll get answered, and the more you pander to my good friend Tariq Ibrahim, the more chance that you'll get your question answered. And he's vigorously nodding his head off camera.
It's not an exaggeration. It's the actual truth.
It's the actual truth. There you go. So tonight's topic, I can screen share this one. Is that cool? Okay. I think it's on, right? Yep. So it's called, this is pre-proof, which means the article has not been published yet, but it's being submitted and they've accepted it. Higher probability of live birth after transdermal testosterone pretreatment in women with poor ovarian response undergoing IVF, a systematic review and meta-analysis. And the final author is Dr. Koulibianakis, who is a very, very highly intelligent, very well published Greek physician in the infertility world with some really amazing literature and some really amazing studies that he has done, and a lot that are really groundbreaking. So this topic is not groundbreaking. There are previous meta-analyses on the same topic, but they really did a relatively good job with this particular report. And it's new, and so I thought I'd bring it to your attention so we can review it with you guys. The idea behind this, we can stop screen share. The idea behind this is that in the ovary, if you can do something to stimulate having more antral follicles present, antral follicles being the little eggs that are going to grow into the bigger ones, excuse me, that you can actually improve the chances of having more follicles there. More follicles probably means more chances at embryos, more chances of embryos means a better chance of getting pregnant, more chance of getting pregnant means a higher chance of live birth. That's the philosophy behind it. So one thing people have noticed is that if you give patients testosterone, you can increase that antral follicle count. And the testosterone is essentially acting, and I'm going to make this as simple as possible for you, kind of like food for the eggs to grow. So if there's more testosterone there, there's more food. They like more food, so they're going to grow better. So this is the philosophy behind it. And the reason that people have tried using testosterone as a primer to grow more eggs and get more live births and so on and so forth. So there have been several individual studies with mixed results, some of them non-significant, some of them borderline significant, but there are only a few meta-analyses. Now, the difficulty with this is no one has a uniform approach. So the first question is, who do you include in your study? Are you including people with only weak ovaries, only very weak ovaries? Were you strict about the criteria of who you selected? Are you using poor responder criteria like the Bologna criteria? All of these things are imperative. So you've got to decide who exactly is being considered in the pool of patients that are being treated. Second problem, when are you starting the testosterone? Some studies did 10 days before the stimulation. Some did 56 days before the stimulation. So obviously there's a big, sort of variation there. If you're not doing the same thing for everyone, it is hard to merge these studies into one big systematic review or meta-analysis. And the third part is you got to make sure everything else is the same. Did you give them the same kind of testosterone? Did you give them the same dose of testosterone? How did you manage their IVF cycle? Did they all get ICSI? Did some get ICSI? Were they getting PGT? Were they not getting PGT? So all of these things are critical. So the first thing I'm going to tell you is there's lots of variation in the articles that they put in this trial. When you're talking about a meta-analysis, and you'll pardon the expression, but it is crap in and crap out, which means if you take a whole bunch of junk studies and you put them into a meta-analysis, yes, you're going to get an answer, but that answer is probably not that valid. So in this particular study, they did try to be strict about the studies that they selected, but there's still quite a bit of variation there. So you do have to take everything that comes out of this with a grain of salt. So the first thing they did was they selected how many trials they were looking at, and their graphs are impossible to read, so I apologize for that. But they basically ended up limiting it down to 2012 publications. They removed 801 because they were duplications. They screened everything else and ended up with 17 studies from 801. From the difference between 2012 and 801. So 1,211 studies. And then they ended up finding only 8 that met their criteria, which was that it had to be a randomized controlled trial, and they needed to have testosterone used through transdermal, which is like a gel or a cream or something. And they also had to make sure that they had outcome data for either pregnancy or live birth. So reasonable criteria, not 100% perfect, but reasonable criteria for this study. So they ended up with 8 different studies that they included in here. And then they analyzed it for a whole list of things that they wanted to know in terms of outcomes. So the first thing was, how are these studies conducted? So everybody got transdermal. They were all randomized control trials. So that's important. The doses were actually fairly tight, usually between about 10 to 12 milligrams per day of this transdermal testosterone. If you're using androgel, that's basically what they were using. They did treat people only that were getting IVF, but they looked at both normal IVF and they looked at ICSI. They did not look at patients that had PGT or did not have PGT. And they also included different protocols of what medications were given, what doses were given, whether there were dose adjustments. That was all permitted. They also had some studies where there was GnRH antagonists used, like cetrotide or orgalutran, and other studies where there was downregulation with the GnRH agonist used, which is unusual these days and would be very unusual in patients that have weaker ovaries, but maybe they meant it in terms of microdose flare, that I don't know. So they did have a variety of different approaches in terms of the techniques that were used in the stimulation. They also had quite a variation in the timing of retrieval from the actual trigger shot. So we typically have always done about 35 and a half hours. There is a new study that was picked up by my amazing lab director that suggests that you can get improved euploidy rates, meaning genetically normal embryos, with a longer trigger time. So we are going to be moving to a 37-hour time, maybe even 38 if we don't lose a lot of eggs at the 37-hour mark. And so these guys included anything from 35 to 40. So again, that can vary the outcomes because in this new study, separate from this one, it did show that there's an improvement in outcomes if you're waiting longer. So I don't know if they waited longer in one group versus another. We don't know that. Okay, so what did we actually? Oh, and the timing anywhere from 10 to 56 days. So they don't have a neat little graph for you guys. So I'm actually going to read you the numbers, and I apologize. I love putting up the data for you to see. It's super sketchy on the actual images here. I'll see if it looks better. Yeah, can't really see that at all. Can you? No, that won't work. I'll go back and just read it. No, it's just really fuzzy for some reason. Okay, so the primary outcome was live birth and clinical pregnancy. So remember, live birth is having a baby. Clinical pregnancy is seeing a heartbeat in the pregnancy on ultrasound. So the most important part of this was that the odds ratio for having a live birth, if you got testosterone priming versus no testosterone priming, was 2.07. And that was highly significant. What does that mean? It means that there was a 107% increase in your chances of having a live birth. What does that mean in English? You're more than doubling your chances of having a live birth if you're a poor responder and you use testosterone therapy. That's huge. I mean, we don't see that in anything that we do in the fertility world. 100% increase is unheard of. So this is a massive jump forward in what you can achieve in a very sort of devastated and difficult group of patients. So definitely big news, very, very important. Clinical pregnancy, which is seeing that live heartbeat, was 2.25, which means you have 125% increase. So not just more than double, it's double and a quarter more. So you are getting a huge increase in the chances of getting that clinical pregnancy. What about other features that were statistically significantly positive? So they looked at the duration of your ovarian stimulation. It was almost 1 day shorter, which is good because if you follow our show, we always tell everybody don't stimulate for more than a maximum of 12 days. So if you're on 13, 14, 15 because you're a poor responder, this might be the trick that shortens up your cycle a little bit and lets you get your eggs ready faster, which is important for your egg quality. The total dose of gonadotropin that you use down by an average of minus 368 units. That's a pen, like a Gonal-F pen. So you're saving $400 or $500 with that. Endometrial thickness, not really important for us because we don't do a lot of fresh. But if you are doing a fresh cycle, reasonable to look at. It was almost 1 millimeter thicker, it was zero point 0.8 millimeters thicker. Might be reasonable to try on patients who are going into a uh, a frozen embryo transfer cycle with thin lining. I don't know of any studies that have looked at testosterone use for those patients. Maybe it might be beneficial, although it'd be trickier around the time of embryo transfer. Cancellation rates massively decreased. It was a 63% decrease in your chances of getting canceled. Again, that's absolutely phenomenal. Huge, huge numbers that make a big difference. And they also looked at the number of eggs that you retrieved. And interestingly, there was a improvement in the number of eggs that were retrieved, but it was pretty minimal. You're talking a difference of about one, so not anything significant. They then looked at the things that actually showed up as not being significant, and these are important too. So your estrogen level on the day of trigger, not statistically significantly different. The number of follicles greater than 17 millimeters, which are the ones we kind of are aiming for, although we actually use like sort of 15 and a half, 16. On the day of triggering, no difference. It was the same between the the testosterone group and the non-testosterone group. Number of mature eggs, not any different between the two groups. Number of eggs that were normal in terms of their development, not any different. Number of embryos transferred, not any different. And in the miscarriage risk, they actually said there was a difference, but there wasn't, which was confusing for me because the confidence interval crossed one. So there was no difference in miscarriage rate. And the proportion of patients that actually made it to an embryo transfer was also the same. So where's the important part of all this? It's in that live birth rate and that clinical pregnancy rate. You are more than doubling your chances of success. Now, I have to say, for the last like sort of 6 months or so, we were always ahead of the curve, and we've been giving our patients testosterone therapy in addition to DHEA, and it works very, very well, and we have seen good outcomes with it. But this is very, very striking data to support this idea. And I met Dr. Kolobianakis in Milan when I was at Esri this summer. Super interesting guy, very, very bright. I talked to him about this paper because they had presented it there and several others. And so this was great to see it finally getting published because this is very, very valuable data that can make kind of a paradigm shift in what we do. Should everybody be getting testosterone therapy if they're a poor responder? Probably yes. This is pretty potent data and worthy of consideration. Does it have any side effects? Is the one thing you should all be asking. And if you haven't already, you should be. So the answer is not that anyone has noticed. The only thing reported in any of the studies was itchiness at the site where you rub in the testosterone. Nothing beyond that. Now, do we have long-term data on women using short-term testosterone? No, we don't. Are there any concerns? I have read about concerns that it might increase your risk of breast cancer, but it's a theoretical concern. There's absolutely no proof that that is true. So beyond that, we actually don't have any concerns with regards to testosterone use. You're not going to turn into a guy. You're not going to grow, a beard from a couple of weeks of testosterone use. So it is safe to use for a period of time. So is it a fact or a fiction that testosterone can really make the difference and double your success rates? It's actually a fact. It does appear that testosterone supplementation prior to and through your stim can actually make a significant difference in how you do. And you should definitely talk to your doctor about it and consider this. Thank you so much for joining us for this episode of Fertility Fact or Fiction. We will now take your questions live. And Tarek, I'm sure, has been working on it because he hasn't even looked at it once. And like, you're like blazing through everything, aren't you? Is it a killer show again? That's awesome. All right. Fire away.
Hi, Dr. VNT. Is it true that taking the flu vaccine 10 days before FET improves chances of implantation? There was a study done by Dr. Gletcher in New York City in 2017, but I could not find the final results.
I've never seen that or heard of that. I would be absolutely opposed to that. You are activating your immune system in a very vigorous fashion in the worst time possible to do so. So we never aim for doing that. If that were true, we would be seeing a higher rate of success in patients that got the COVID vaccine and then went on to do infertility treatment. And that is simply not the case because it has been looked at. So I don't believe that that's true, and I can't understand biologically how that would be true. So that's very interesting. But no, I don't. I don't believe that that's the case.
Earlier today on Instagram,
Okay.
does testosterone priming improve response in non-responders of the TFIT AMH AFC?
I don't believe that that's being looked at, but it would probably be worth a try. I guess my question would be, why are you not responding? And I would want to know more about you. So I love the challenge cases. So why don't you reach out to me, DM me, and I'll answer you, and I'll figure it out from your history. We may need to do a consult, but I can usually get enough details to figure it out.
Hello,
Oh,
low AMH and DOR.
okay.
Which med would be best, Gormalef or false?
Um, So, strictly technically speaking, I'm not aware that there's any difference. I am a Gonalef fan. It is a very strong product. It's kind of international. Everybody uses Gonalef. So we usually use Gonalef, but there's nothing wrong with using Folstim. Having said that, there should always be a balance of recombinant to urinary because it gives you the best outcome in terms of egg quality and embryo normalcy. So I would focus on balancing your Gonalef with a urinary product. We use Menopure, but it doesn't matter which one you want to use.
Do you test testosterone when on DHEA, and what is the ideal level?
Ideal level. Yeah, we don't actually. So there are a lot of people I've seen lately that are being told to stop their DHEA because their levels are too high. That actually doesn't make any sense. It's fine to go ahead and stay on a high level while you go through your stim. So don't worry about it. Yeah, and we don't check your levels. We just plow ahead because you're looking to get the levels up. You want to overfeed your eggs.
Do you recommend gold media?
Oh, so that's an embryology question. And if you ever want to get your head chopped off, tell your embryologist that you want them to switch media. So I don't believe we use gold. We use a different type of media, but embryologists are extremely, extremely sensitive about their media choices. I would never dare to question Dr. Khosravi about what media she uses. So she has her reasons for using the ones she does. The only time we ever discuss media is if there's a new media that comes out that has benefits like the GM CSF media that we use. Then she'll have that. And then we do add embryo glue to all of our embryo transfers. So that's added to the media. But I would never tell her which one to use. And gold media is a type of media. So that I don't have any information about because she's the one that decides which media we use. Never, ever, ever question an embryologist media use. There's actually a large company buying up a bunch of fertility centers in Canada right now. and they are telling them to switch media for cost control and uniformity, and that is going to wreak havoc with everyone's success. So I don't believe in doing that.
Under the media, stakes,
The gold wrap,
high stake plus.
they covered the steak in a gold wrapper, a gold
Yeah.
foil.
So when they were, so
Oh,
on Earth is getting wrapped in gold, but
no,
it's the referring to. Yeah. So yeah.
it's the fluid that you grow the embryos in.
Oh, I see.
Yeah, culture media we call it.
Cultured media.
Yeah,
Yes.
yeah.
Not just a normal media.
No, not like social
This is
media.
this is a cultured media. A little bit more sophisticated.
It's a little more sophisticated.
Yeah,
Yeah,
yeah, yeah.
yeah.
Should I get the flu shot before an FET cycle?
No,
Easy enough.
yeah.
Hi, Dr. VNT. How soon after lab should I do another round of IVF?
After laparoscopy,
Mm.
soon. Yeah, I mean, your endo will never be better than right after your surgery. So, like maximum, wait a month or two and then do it. I would definitely do it before 6 because we know that that's the point at which your endo can start coming back. Oh wow! Psh, yeah. All right.
Unexpected RPL.
Okay.
All labs normal.
Sorry.
Genetics normal. Would you recommend IVF?
Ooh. Well, there's a lot more to test. So test first for infections in your uterus, check your immune system, do a hemophilia screen, make sure your thyroid is normal and you don't have thyroid antibodies, check your partner's sperm DNA fragmentation, make sure your weight is appropriate, make sure your diet's appropriate, make sure you're getting enough exercise, all those same things. No one can be smoking, drinking, or using drugs. And then if you still don't have an answer, and yes, I would do IVF to determine if you're producing embryos or not. That's important, but not before.
I failed IUI. How many rounds do IVF?
That depends on your age. Less than 38, up to 6 rounds will give you a cumulative 30% success rate for IUI from one very large Chinese study. Over 38, 3 for a cumulative rate of 19%. So I would stick with those numbers and do up to 6 if you're comfortable doing so. Some people want to stop after 3 if you're under 38, and definitely if you're over 38, I wouldn't do more than 3.
Yes, it's possibly chocolates at IVF. Irretrievable amount.
Yeah, I mean, if it's a chocolate cyst, for sure, it's going to impact your egg yield because chocolate cysts decrease your AMH. It's going to or make it more difficult to access your eggs. I did one the other day on a lady that had a tiny little follicle, but the follicle was right in front of where the other follicle was. Oh, here's a drawing one. Yeah, I know you. I know you love my. It's so funny. Okay, I got it.
At any time you got born.
Yeah, just draw. It's art. Yeah, I don't think I can't draw a straight line with a ruler, man. I don't think anyone's gonna appreciate my art. Okay, so if this guy here is your ovary. Oh, I didn't share my screen. Okay, hang on. Sorry, guys. Screen share coming up. Okay. So this is your egg, and when we're watching it on ultrasound, the needle usually is going to come on an angle that is basically like this. Why is that not drawn? Oh, of course, it doesn't want to draw now.
Protest.
Okay, your needle's going to come on that angle. So if you have an endometrioma sitting right here, and you've got another follicle right there, if this one's the endometrioma, which I'll fill with red for blood, right? So here's your endometrioma. You can't go through an endometrioma. It kills everything because now you're sucking that chocolate fluid into the needle and it'll damage all the eggs. So what do you have to do? You got to like pivot the ovary to twist it so you can actually get the needle around it to get to that other egg. A, it's not easy. B, if you're not good, it's dangerous. And C, you're kind of tearing the vaginal wall when you're pivoting needle after it's in there. So all of this causes pain, bleeding, soreness, discomfort, injury if you're not careful. So number one, you can't easily miss the ovary. Um, and number two, or miss the eggs, I mean. Number two, you're damaging the ovary because if you have a bigger endometrioma, so let's go back to, if you have a big endometrioma, like it's this large, so it's putting pressure along the edges of the ovary. Your eggs are actually sitting all along here. Okay, that's where your eggs are. They're all on that outer edge of the ovary. This is where you're going to see all your eggs. So if you're putting pressure on that part, and it's all like pressure all through here, you're killing the blood flow to those eggs. By doing that, you reduce the number of available eggs that because they're not getting the blood supply they need. So having an endometrioma reduces your follicle count. It reduces your access to follicles. On top of that, it creates an enormous amount of inflammation. So even if you do get decent eggs, when you go to put them back in, you're fighting all the inflammation caused by the endometrioma. So yes, endometriomas impact virtually every single step of the IVF process. And a lot of centers don't pay attention to that. I was just on the phone with a lady from a Toronto clinic, a large Toronto clinic today, where they weren't paying attention to that. And she had done, I think, her ninth cycle of IVF. That's crazy. So she needs surgery. And I told her, don't do any more IVF. You need to go and do surgery first and get your endo cleaned up and then just do your embryo transfer with an endo protocol. And that's what's going to yield you better results, not just endlessly paying us to make more and more and more embryos. That's not helpful for people. You actually need to improve the chances that embryo is going to stick. Otherwise, making more embryos is useless, right? So, yeah, be careful with that, guys. You can see screen sharing.
I'm starting my FET for 3 months. LUP is up. How do we prime lining with LUP in system?
With LUP?
Hmm. Lupron?
Maybe. LUP is up? You got to define LUP for me. I am not familiar with that term. Sorry. So tell me what the LUP is. If you mean Lupron, it wouldn't be up. Maybe she means luteal phase progesterone? Not sure what LUP is. So let me know.
Is 3 months of Lupron necessary for endometriosis or FET?
No, 3 months of Lupron and letrozole is necessary. 3 months of Lupron alone is proven to not help you.
I get sick every week FET for 12 hours straight, 2D. Is my body rejecting the embryo?
Well, that's on you. I would actually recommend you do a mock cycle where you don't transfer an embryo and see if it's in relation to the medications you're taking. And then if it is, you try different medications. If it's not, then yeah, I would be worried that the embryo is the only other thing that's in there, in which case you probably need to look at an immune protocol to quell your reaction to the embryo.
Hey, Dr. V, thanks for doing this. Been binging your videos, looking for some advice.
Awesome, sure.
I've had two looking. I've had two cycles, I guess, looking but failed IUI cycles with letrozole.
Okay.
Then a third IUI with 50 of gonal F.
Okay.
My follicles stopped growing at 12 millimeters for a few days. Then I set an LH surge and we missed the window. Then a fourth IUI cycle where we did 75 gonal and cetrotide. Follicles grew, but I still ovulated early despite the cetrotide.
Huh. That's unusual.
Also, high CA 125, RE says X quality is the issue. What IVF protocols could work starting in January? Sorry for the long messages. Hope it makes sense. You guys rock. Wish I was in Windsor.
You don't have to be in Windsor. We help people from all over the world. I just was talking to an Australian couple that's coming to us for fertility care, so you're welcome to come to us from anywhere. That's a really interesting case. Cetrotide won't work if you start it too late or if your estrogen level is too high. Remember that your brain is what's actually recognizing the time that it is appropriate to send out LH, which is the ovulation signal to your ovary. Your brain does not know how big your follicles are or how many of them you have. All your brain sees is the amount of estrogen that's in your blood. So if there's a high level of estrogen, even if you have 12 millimeter follicles, which are not big enough to ovulate, your brain will send out the signal. So if you have 10, 12 millimeter follicles and your estrogen levels, I don't know, 3,000, you can surge the LH and try and release those eggs because your estrogen level's high, even though your follicles aren't ready. So if you start cetrotide or orgalutran or whatever antagonist you're using too late, it won't work. And if your estrogen level is too high before you start it, it also won't work. So it is extremely, extremely critical that you figure that out and deal with it. And so I would want to know exactly what happened with your cycle. So like send me your stim sheets and then I can figure out if they waited too long or didn't do the right thing or whatever the case was. So if it's just a matter of starting a day or two earlier, that would likely solve your problem. If that didn't solve your problem, you have to use a long protocol, which is very unusual these days, but workable. Just higher risks of hyperstim because you need an HCG trigger and then we worry about the hyperstim part.
Hi, Dr. V and T. There's a law in my country that only 12 eggs can be fertilized and the rest of them must be frozen unfertilized.
Oh, cool. What country is that?
I'm doing it elsewhere.
Sure.
I'm 33.
Yeah.
AMH 28
Whew.
picomoles per liter. Fit, BMI 18.5.
Oh, wow.
Too
fit.
Too fit.
Yeah.
On low dose on lavoxerin and on cabergoline.
Cabergoline. Yeah.
Cabergoline.
Yeah.
You said last time that CD21 ovulation means poor eggs. What do you think about 16, 17? What would you say is the cutoff?
Yeah, like 17, 18, that's starting to get a little long in the tooth, as we like to say. So I wouldn't trust the quality of the eggs when you're getting past day 17, 18. Yeah. And I'd love to know which country you live in. That would be interesting. Certainly if it's if they're only allowing you to make 12 and they're making you freeze the rest of the eggs, come to us. We don't make people freeze their eggs after a certain threshold, unless it's actually over 25, in which case it's massive overkill. So we don't force you, but we offer you the option to freeze eggs above 25.
Does using HCG as a male improve sperm morphology? And does using HCG for long periods, 6 to 12 months, hurt fertility in any way? We all know that antioxidants improve sperm parameters, but does overusing and megadosing vitamin C, E, D, zinc, and psyllium have bad effects on fertility, or is it okay to do it?
Yeah, I don't know about megadosing. I wouldn't megadose anything. Taking an appropriate dose to meet your daily requirements is what you're trying to do. I'm not aware of any evidence that shows that the vitamins are detrimental. It's actually questionable whether or not they're helpful because there is conflicting data on that. We do use them, I am a believer, but there are studies that show that it is not useful, and we're always open and transparent about that stuff. So I'm not sure that you're going to do any damage. I certainly doubt that you would do any damage. But that is important to be aware of, that there are people that say it's not helpful for you.
Hi, Dr. V and T. Smiley face, pop balloons, and prayer or high fives.
Okay.
You know, somebody said, when the
It's
hands
supposed
go
to be
together,
a high five?
it's supposed to be a high five. Do you know that?
I didn't know that. I thought it was prayer. Who knew?
I
Yeah.
Retrieval number 4.
Okay.
And doctor put me on estradiol for a week after my period before starting injections. Effects on
Whoa,
results.
whoa, whoa, hang on a second.
Yeah.
What? Retrieval number 4.
Uh-huh.
Doctor put me on estrogen a week.
Estradiol.
Yeah, a
Yeah.
week.
For a week after my period, before starting injections.
That doesn't make any sense. Maybe they meant before my period. Okay, yeah.
Effects on results. Is this BS? Currently, day 5 of stims.
So I think what you meant was that your doctor put you on it for a week before your period. I hope that's what you meant, which is estrogen priming. And if you watch our video from about a month and a half ago now, it proves that that's actually detrimental. So the only 3 primers that are good are DHEA, testosterone, and human growth hormone. Don't use estrogen, and definitely never use a birth control pill. So yeah, estrogen priming actually decreases your chances of success.
T, what up?
T, what up?
What up? How do I deny that?
I know, yeah.
How do I know?
Yeah.
What up? It's all up.
Don't worry, Merv. I'll keep them honest.
Dr. V.
Dr. V, okay. Yeah.
Hi.
Yeah.
You notice?
I
Hi.
don't get a what up.
I got T, what up? Big one.
Okay.
My lining is trilaminar.
Okay.
Late in cycle, CD 25-ish.
Okay.
Doing medicated FETs now. How long can we stretch it to achieve that?
Yeah, so there's actually no evidence that it's detrimental, although we all kind of know that it is. So if it's taking past like day 20, 21, we all start getting nervous for sure. Yeah, but there are people that need a month. So if you need a month, you need a month.
As a healthy man with normal sperm parameters, but smoking cigarettes and eating junk food, 25% body fat,
Okay.
and taking Adderall for ADHD, what consequences would that have on my future child's life? How many sperm samples in average a man with normal sperm parameters have to freeze in order to impregnate a healthy woman with it later?
Oh, good question. Okay, so smoking will annihilate your sperm performance. It's an 80% decrease in success. It's a 1,183% increase in the risk of miscarriage for your partner. So don't smoke. You can't smoke and try and get people pregnant. It's a disaster. If that's not enough to convince you, your child will grow up to have higher chances of heart disease and cancer if you are smoking when you produce the sperm that you're going to use to produce the child. So smoking and fertility are a total no-go. We actually don't let people smoke in our program at all, like zero. So we will make you quit. 25% body fat will also have an impact. Your body is going to be chock full of inflammation. Your sperm DNA fragmentation will be extremely, extremely high. The junk food is obviously not helpful either. So all of those things need to be changed if you're thinking of freezing sperm. How many samples do you need to freeze? It depends on the quality of your sperm. I mean, some sperm isn't even worth freezing because it's so badly damaged. Other sperm, you might only need 1 sample and it's enough for several tries. And it also depends if you're thinking of doing it for IUI or thinking of using it for IVF. For IVF, 1 ejaculate would be more than enough for several IVF cycles. But for IUI, you may need several ejaculations. So that's a great question. I would need to know your sperm parameters. You cannot smoke. You got to bring your body fat down and please start eating healthier.
I was actually curious too what kind of junk food he's eating, but I guess that's not. That's not important.
Yeah. Well, you and I don't always eat great before the show.
That's why.
Well, we do eat great, but it's not good.
Yeah. It's questionable.
Yeah.
Hi.
Hi.
Yeah. No Dr. V, no T, no nothing.
It's just neutral. You got to appreciate. I respect a little neutrality.
I think they must be new.
Yeah.
That's why I'm reading their question. I'm like, this is a lesson.
They don't know you yet.
They don't know. They're lucky to get their question.
All right, go ahead.
I recently had a failed IVF cycle.
Yeah.
Ended
Sorry.
in CP.
Clinical pregnancy.
Clinical pregnancy.
Okay.
I do not have PCOS,
Okay.
but high AMH and androgens. I had 17 eggs retrieved,
Whoa.
5 high-grade embryos, 1 tested as normal, but was a CP. 2 prior miscarriages, 1 was tested as a trisomy 10.
Oh.
I'm turning 39 soon and can only afford to do 1 more round of IVF.
Okay.
Can I either pay more and do it soon or wait for funding in April? Can I afford to wait that long?
Well, you can afford to wait a long time because you're making a lot of eggs. Your genetics are what are getting compromised. So what you want to do is make sure that you're working with a team that can get the most number of eggs to become blastocysts, which is really important. And then you want to make sure that you get the highest number of genetically normal embryos, which does require some tweaks because there are certain protocols that yield higher numbers. For anyone that is wondering, the big genetics companies have data on which clinics have the highest rate of genetically normal embryos, and it is not uniform by any means. So there are clinics that have higher rates of genetically normal embryos than other clinics. That's because of the protocols that they're using. So it's very, very important that you pay attention to that and make sure you're working with a team that will get you a high number of embryos, like blastocyst embryos, and a high number of genetically normal embryos. Beyond that, because you had normal embryos before and it didn't work out, you need us to figure out why. So actually, before you even start your IVF, you need someone that's going to pay attention to why your previous embryos didn't work. So that's all the testing that we do, or anyone can do. That's all of the evaluation. That's your saline infusion sonohystogram, your fertility testing, your hormones, your thyroid, your vitamin levels, your partner's sperm quality, your habits, his habits, your body health, your body mass index, like diet, all of those things. So you need someone that's going to go through it with a fine-tooth comb, figure out every single detail of what's going on, address all of those details, and then get you the best possible outcome. Do not just jump into an IVF cycle because you're worried about time, because that's what I always describe as a really good way to make us rich and a really bad way to get you pregnant. Go to someone that's going to spend the time to figure out what's wrong first and then put you through an ideal IVF cycle, knowing what they need to do to get you to the outcome you want. You seem overwhelmed tonight.
There's a lot.
There's a lot?
There's a lot.
It's going to be a 2-hour show?
I don't know.
It's going to be a really long show.
I don't know.
Wendy!
Hi, Dr. V.
Yep.
You are awesome.
Oh, thank you. It's all him.
I'm nowhere mentioned in here.
Yeah, but you are awesome.
But you are awesome.
Thank you.
I'm currently on Lupron, Letrozole, and Agestin.
Okay.
And I have endo and adenosis.
Adenomyosis. Yep.
Adenosis, yeah. But severe. Can my transfer be successful?
Oh.
Both severe. Can my transfer be successful?
So that's like a top of the totem pole God kind of question, and I'm more like the dirt that the totem pole is buried in level. So, yeah. So listen, I don't know if it can be, but there's always a chance. So if you're doing Lupron and Letrozole, you're on the right stuff. You mentioned Agestin, which actually has estrogen in it, so I wouldn't do that. At least I believe it does. It's not sold in or marketed in North America. I wouldn't use that if I were you, because the whole idea of using Lupron and Letrozole is to eliminate the estrogen from your system. I would definitely want to see about surgery for you first, and depending on how many embryos you have, there's always the option of using a surrogate. If you're worried about how many embryos you have and how severe your endo and adeno are, surrogacy is an option you need to consider. And I say this to all my patients when they only have 1 or 2 and this is their only shot. You got to really consider the merits of what happens to these embryos if we put them in a healthier environment without all the inflammation from the endo and the adeno. It's a really tough thing to live with. It is not easy. My heart goes out to people that are suffering from endo. Listen, I operate on very advanced and aggressive endo, and I hate it sometimes. It can be a brutal disease for people. But the reality is that you have to do all of the necessary things to optimize your outcome, which is having a baby, and you have choices. So you got to at least consider those choices.
Hi. I'm trying to read what you wrote.
That was not profound, man.
Oh, Vivacious V. Vivacious Dr. V
Oh, I like that.
and Treasured Tea.
Oh,
This is great.
that was great.
This
That's
is great.
I like.
I should have picked this first.
You should
This
have. Yeah.
deserves to be first.
That's kind of poetic. I like
Yeah,
that.
yeah,
I'm an
very
honors
nice.
English major, so I love the language.
Yeah.
The diction
There we
is
go.
excellent.
See
Yeah.
that? Yeah.
Vivacious V.
Nice vocabulary.
Nice vocabulary.
Nice
Yeah.
vocabulary.
Yeah.
I have been binge watching the
Okay.
previous FFOFs.
Okay.
This is music to my ears, by the way. And almost have all answers needed to complete my choose your own FET protocol.
Oh, cool.
Presented to my doctor.
Okay.
This is
We're making a difference,
We're making
man.
a difference.
Yeah.
This is just wonderful.
All right. That's good.
I heard your video
Uh-huh.
on the study about adding progesterone for an endo patient.
Yes.
The study was for program cycles.
Yes.
I'm doing the 3 months of Lupron and letrozole cycles instead of progesterone.
Okay.
Would you suggest adding more progesterone in the modified natural letrozole cycle? What is your ideal progesterone level after FET for patients with endo? Thank you.
So in that study, they showed that the average was 138. I've got it right here. Let me see if I can find it again. I will, but I got to find the level first. Oh yeah, here. So there. Yeah, you can screen share.
Screen?
No, no, this is good.
Good, okay.
Yeah, this is good. So this is that study that you're referencing, which we reviewed, I think, 2 weeks ago, because last week we had Mel on. So yeah, it was 2 weeks ago. So their differentiator was less than 118 and more than 118, but their average, if I remember it correctly, was like 138, I think. Is that 138 or 150 for the progesterone in the people that had progesterone over 118? So their cutoff was there, but the average was actually much higher. So yeah, you want a fairly high level, but you definitely want it over 118. Let me see if I can find where the numbers are. Serum progesterone concentration of all cycles was 103. Reproductive outcomes. Oh gosh, I don't remember where it was, but I know I read it and it said that the average was quite high. It was like 150 or so, something like that. I will find it for you guys and maybe we will post it. But the reality is, oh, maybe it's here. Nope. I'll have to find it, guys. But the reality is it was quite high, their average. So I would aim for a pretty high average level.
Yeah.
Oh, here it is.
Actually,
pop it back on.
Your,
Are we glitching?
your yellow duck just decided to
Uh-oh.
something. Let everyone know, just bear with us.
We're just trying to fix our software, guys. So be patient with us for 1 second.
1 second.
Are we going to have to respool?
Maybe, yeah.
Oh, no. That would be bad.
Yeah, for sure.
Are we still on any platform?
You're still on, we'll see what happens. You're still on Facebook and YouTube right now, but I might bump you out right now as well. Hold on.
No, don't bump us out. Just leave us on those ones.
Poor Instagram people.
Yeah, just send a message to everybody on Instagram and tell them to jump onto YouTube. It's not like they don't have YouTube.
Give me a sec. Let me see. 1 sec.
Oh, are these like
I answered
500
some.
different questions that
Yeah.
you moved down?
There's a bit.
Oh boy, this might be a lot to handle.
Yeah. Now you know why I had that face.
I see that. Yeah. Let me see if I can find the questions I had. Oh, I answered that one. Okay. Here's another one. Hello, All Stars.
I like it.
3 weeks of headache with PVCs. Winded after second egg retrieval with hematoma. Advice on how long to wait to start third cycle. 39 and impatient but not feeling great. Definitely don't start if you've got a hematoma. That would be dangerous. And then same reader or watcher, how long to wait to start FET after salpingectomy? I'd probably wait a month. After that, you are okay. Thank you. You guys are 1000% the best.
I love 1000% the best.
I like 1000% too. That's pretty good. I'm looking for other ones here. These are all you responding to people.
Go from there. Here, I'll tell you.
I got to get their question. No, there were some that were DM'd to me.
LH, ESTR, CBC, AMH, SHG, all were normal.
Okay.
Same-sex couple, donor sperm.
Okay.
Thank you. What additional testing would you order before proceeding with IVF? Had labs for thyroid.
As long as you've done your thyroid antibodies, vitamin D. I don't know if I heard you mention that one. No.
Hi team, Dr. V. What's your transfer protocol for someone with endo and adenomyosis?
Letrozole and Lupron, well, surgery first. Lupron and letrozole for 3 months. Letrozole for 5 days extra.
You're back on Instagram.
Oh, perfect.
Just miraculous for no reason.
Melatonin, antibiotic, then probiotic, double progesterone, vaginal and PIO. Keep your levels high, over 118, and that's pretty much what we do. Minimal to no estrogen.
Oh, that's struggling. Instagram's struggling today. Not sure what's going on.
On and off.
Yeah.
Weird. You better contact Yellow Duck and say, make a better package. I'm sure somebody else has software that does this now. It can't be just Yellow Duck. We should reevaluate.
We should reevaluate.
Yeah.
This is the second time.
Yeah.
They're putting us in the. So when I respooled, some of the wonderful questions
Disappeared? Uh-oh. Guys, something happened with the software that lets us broadcast to multiple platforms. So if you've been asking questions, ask again. You can go back to
Facebook and YouTube people have to re-ask their questions.
So if you're on Facebook or YouTube, you got to re-ask your questions, guys. Sorry about that. We'll stay on a little extra tonight and answer as many as we can. Maybe we're crashing it because too many people are watching.
Nothing that should crash it, but yeah. Fluid in uterus on day of LA surge.
Oh,
At lining check with natural cycle.
yeah.
Would you cancel FET?
Yes, definitely. If there's fluid in the lining, it's very difficult to make it work. I did drain someone recently and I managed to get the fluid out. I think it was because their cervix was too tight, but you need to know why there's fluid. If it's from an isthmusal from your C-section, that needs to be dealt with. If it's from infection, that needs to be dealt with. If it's from hydrosalpinx, that needs to be dealt with. Tight cervix is the only one you can fix easily. You just stretch open the cervix and the fluid comes out.
So,
Instagram's being horrible.
yeah.
I always say I don't love Instagram.
You do say it. And they must have heard you.
Yeah,
They said, well, we're going to teach them.
we're going to teach them a lesson.
Is it ever too late in a cycle to move forward with FET? Is there any ideal timing?
Yeah, I mean, if it's going too long, it's not good. So that's why I answered earlier. If it's taking more than day 21, that starts making us nervous about, waiting for your lining to develop more. We do it from time to time when we don't have a choice because you just can't get the lining to thicken. But after day 21, you're probably compromised.
Hi, my question couldn't fit on IG, so that's why you couldn't understand it.
Oh,
My question is, how do I prep my lining if I'm starting my FET cycle before my Lupron and Letrozole 3 months is finished?
you don't. Don't prep your lining before your Lupron and Letrozole is finished. You wait. And then you extend your Letrozole for 5 days extra past your Lupron. and that'll help you to grow an egg. So past the 12 weeks of the Lupron. So that's how you do it. You don't try priming it or prepping it before. The whole point of it is to not prep it. That's to shut down your endo.
Hi, Dr. V&T. Are SIS and SHG the same thing? If I had a SHG, but I know it was not 3D, would you repeat this if we came to you?
An SIS and an SHG are the same thing, but an HSG is not. So an SHG is supposed to be a saline histogram, which is the same thing as a saline infusion sonohystogram. So SIS and SHG are the same. But an HSG is a hysterosalpingogram, which is X-ray with dye. So those are two different things. If you had a HSG, the X-ray version, yes, we would do an SIS. But if you had a SHG, the ultrasound version, no, I wouldn't repeat it as long as it was not more than like 6 months or a year from the last one. If it's more than 6 months or a year, we probably would.
Regarding my earlier two, my doctor put me on estradiol after my period started on CD3 for a week, and then started me on stims right after to pause cycle for scheduling. Effects on retrieval results.
Oh, yeah, that's a disaster. Don't ever let somebody do that for you. It's not a good idea at all. You don't want to get suppressed before you start a cycle, so don't do that. That's a mistake.
Some doctors. Some guys.
Well, that's not me saying it. You could say it off
I
camera.
I can't. Camera. Don't even see me. Who said that?
Yeah, those came from his lips, not mine.
Yeah.
Yeah.
So basically, my appointment before my vacation is just for baseline ultrasound and no blood work. This is the person asking regarding
Must have been something else.
The FET cycle.
Yeah, your FET, it would just be baseline ultrasound if you're doing the Lupron and letrozole. Yep.
Hi, Dr. V&T. Just wanted to drop in and say hello and let you know my laparoscopy is booked in for November.
Yes. Awesome. I'll look forward to operating on you.
Yo, Techie T.
Techie T.
Question for Dr. V. I appreciate that entire intro. The whole thing, I'm feeling that. The whole thing there.
Yeah.
For the record, Instagram just like had a massive like
Collapse. Okay.
I don't know what's going on here.
All right.
I don't want to lose the questions again and try and
No, it's
rescore it,
okay.
you know?
It's okay.
Yeah, question for you, Dr. V. What odds do you give to an IUI that triggered a 21 millimeter follicle with a lining of 8.2, 15 million swimmers inseminated? Wowza.
Depends on your age and what the other factors.
Did you plug in?
No.
Yeah, let's just make sure we don't have any other glitches.
So anywhere from a low of maybe 5% to a high of 25. Like, I need more info. I need your age, body mass index, your habits, the sperm quality. But average would be like 10 to 15%.
Thank you, Dr. V and T. 3 miscarriages, 2 over 6 weeks, and a twin pregnancy at 5 months. Obi put me on tacrolimus,
Yeah.
prednisone, IVIG, baby aspirin, and tinzaparin.
Okay. Tinzaparin, yeah.
Question
Yeah.
is, are tacrolimus and prednisone safe? And prednisone safe?
What? Safe?
It's gotta be
Yes,
safe.
they're safe. Yeah.
Hey, Dr. V&T. Oh, hi, Dr. V&Tarek. Wow, that's a good one. Even good spelling.
So
Hey.
it looks like it keeps freezing. People are telling us.
Yeah, this is
That's what's
exactly what
happening.
It's just dying. Yeah.
Alexis, there's something wrong with the system. So thank you for pointing it out to me, but we don't have a way of fixing it right now. It's a software glitch. Major software glitch. Yeah, we need to get rid of it. So there's a program we use called Yellow Duck, which lets us broadcast to 4 different platforms at the same time. And apparently Yellow Duck has its head in the sand.
Someone shot that duck.
Yeah, someone shot that duck.
Hunting season and it got aggressive.
Okay, keep going.
Thank you for everything you do.
Yeah.
How long should you try to conceive naturally before considering an IUI?
Oh, good question. Less than 35 years of age, regular periods, a year. Irregular periods, immediately go and see your doctor. You don't need IUI, but you need to be seen. Over 35, 6 months. Over 43.
Hi, Dr. VNT. After multiple failed retrievals, we are considering donor sperm. As
Oh,
per
okay.
genetic testing, I'm a high-risk carrier for a rare genetic condition. Do all donors receive genetic testing?
In Canada, they do. Not sperm donors, though. They just go through a genetic questionnaire. We test all of our donors for eggs with genetic testing, but sperm is different. Some of them do, though, and more we're seeing that the sperm banks are doing genetic panels on their candidates.
Hi, Dr. V. Hi, T.
Hello?
Thank you so much for doing this. Your impact is huge.
Oh, wow.
And very much appreciated.
Okay.
What would your protocol and meds be for stimulations in FET? 30-year-old, healthy, normal BMI, SHG, normal,
Okay.
thyroid, AMH labs, normal,
Yeah.
using donor sperm, last vial, same-sex couple. Thank you.
Lots of vitamins. What was the AMH?
AMH, normal.
Oh, it doesn't say. Yeah, lots of vitamins, healthy diet, no smoking, no drinking, no drug use. Gonalef, I would probably, if you're 30 years old, you got a normal AMH, I'd probably go 150 Gonalef, 150 Menopur. Antagonist protocol, double trigger, Lupron and beta HCG. HCG has to be titrated to whatever your estradiol level is and the number of follicles that you have. And then we would do a 37-hour retrieval. And that's pretty much everything we would do on our end. The vitamins are important. If there were concerns about your AMH or the number of follicles that you have, that would drastically change things. But that's kind of our general approach for a case like yours. That should give you very, very good results. We do ICSI for everybody, and then we use a time-lapse incubator for whatever that's worth.
Hi, Dr. V&T. What kind of low-weight heparins are more recommended and safer to use during pregnancy? Lovenox, Enohep, or Frogman? Thank you in advance.
Fragmin, Lovenox, and Inahep are all safe. So any of those are fine. You can use any of those three. They're all the same.
Those are the most up-to-date questions.
Yeah.
Any tips for egg retrieval?
Performing it or experiencing it? So if you're experiencing it, make sure they knock you out. Make sure your bladder's empty before you go in the room. Otherwise, I got to put a catheter in you after we've put you to sleep. Be prepared for some soreness afterwards. Make sure you go somewhere where they will stop at nothing to get your eggs, as long as it's being done safely. So yesterday I did one, I got one ovary, I got everything, couldn't even see the other ovary. Finally thought it was sky high. I actually had to do an abdominal retrieval for her to be able to access her ovary. Got another, I forget, 7 or 8 eggs that way. It's critical you have a physician that's capable of doing whatever is necessary to get the eggs. So make sure you're seeing someone that's comfortable with that stuff.
If I've been unexplained for 2 years with 2 chemicals from 4 transfers and the only thing left to test is NK cells and laparoscopy for possible endo, is there hope? I'm 29 years old.
Oh, there's loads of hope. So you should reach out. We're really good at figuring those cases out. And there's lots of ways to do it. There's fertility testing. There is immune testing as part of the fertility testing. There's advanced hormone testing, thyroid checks, vitamin levels, sperm DNA fragmentation testing. There's lots of stuff we can do for you. Hysteroscopy or laparoscopy, all of those things can be very beneficial. So yes, there are many things that can be done to help you.
Best ways to prevent OHSS?
Don't get very much HCG as part of your trigger. So we use a very limited amount of HCG, maximum 1500 with Lupron, and then we titrate it down based on, what other parameters there are, including number of eggs we get or expect to get, and how high your estrogen level is.
Prednisone dose and safety for FET with autoimmune issues. How much and for how long?
25 milligrams till you're 12 weeks minimum. And safety, it's pretty safe. The only concern anyone has ever expressed is that there may be an increase in cleft lip, cleft palate. I've never seen it in our patients, and half of our patients are on prednisone. And there was another study that showed an increase in bladder abnormalities, but I mean, I've never seen kids with bladder abnormalities because they were on prednisone. So I don't believe those studies yet, but that's what's out there.
Can Matrix be used instead of an ERA? What are the pros and cons of Matrix?
So Matrix is an ultrasound technology which we have been using. I think we're probably going to stop using it soon. We are just about to do a review of our data to see if it actually does make a difference or not. So Matrix just takes your ultrasound image and then predicts if your lining is good enough to allow an embryo to implant. ERA is useless. It's been proven to be useless. There's no justification to do ERA unless you cannot get your lining to thicken and you just want to see if it even is remotely possible to use it as a test to see if there's any receptivity. But from a timing perspective, it's completely useless. Don't believe a word of what ERA says to you. It's not true. So yeah, you can use Matrix instead of an ERA for receptivity. That's the idea behind it, but I'm not sure that it works. Your camera just did its thing.
Oh, this also just decided to clonk out.
We're fully dead now.
So everything just died.
Everything dead.
Let me put it on here.
Do you want to put it on that one?
Real quick here.
I can give you this guy.
Just make sure my...
Does that have a camera?
Yeah.
Oh,
So I don't want to...
you're not on it yet. Hang on, folks. We're coming back.
We're doing overtime today.
We should probably wind it down. Is it OBS virtual camera?
This should be just... No, okay.
There we are. Hi, guys. So we're probably going to wind down the show because it's very glitchy. But let's just read a couple of these last ones. Kayla, hi, what would be your testing pre-IVF consult with you in January? I'm wondering if anything could be done before then to have more info and testing done before that appointment. So we try pretty hard not to do a lot of testing before because I don't know what you're actually going to need, and I really want to know what you need prior to proceeding with testing and treatment and so on. So I know it gets a little bit frustrating for patients, but the testing doesn't take us more than a month, so you should be okay. Thank you so much. Beyond appreciate you both, from Kayla. That's very sweet. My RE says my left ovary sits right underneath a major artery, so she will not be able to go in for follicles on the left side. Yeah, there's always a way to access that, and if they can't, they should just do laparoscopy and sew your ovary somewhere where it isn't involved with an artery. So they should be able to go abdominal, or they should be able to move your ovaries, and I've done that for people before. Hi, Dr. V. Where can we find the data you mentioned on clinic success rates on getting genetically normal embryos? Amanda, that data is not for public consumption. It's actually from the company that does the genetic testing. That's Cooper Genomics. They don't even share it with us. I know where we rank, but they don't tell us who's number 1 or 2 or 3 or anything like that. We just know where we rank in the overall perspective of things, and we were told we were top ranked. So that's all that I know. I was told that we were in the top group in the country for our low number of genetically abnormal embryos. So the company will not disclose what everybody's rates are because that would probably be a huge privacy breach. Which way does this thing go? Yeah, you always go backwards. I forget that. Okay. Doc, I had my second IUI. One IUI failed because of 38% sperm motility, while on second 99% sperm motility, 90% forward progressive, but zero rapid progressive. Is it impossible to fertilize my egg? Well, it's certainly not impossible, but your chances are compromised if there aren't a lot of rapidly moving sperm, for sure. So I would want to make sure that you are doing everything you can to get the best sperm quality. And then, of course, a lot of other things are important too, like age, health, smoking, drinking, drug use, all that stuff. Gia, I've been unexplained for 2 years with 2 chemicals from 4 transfers. Oh no, that one we read. Were you going backwards?
No, I have some on Instagram still.
Oh, you do?
Yep.
All right, let me see if there's any ones we missed here. Oh, wait, I think I just showed one on the camera. No, I think you did all those ones. Go for it. And then we'll wind it down because it's 10 past.
How soon before after FET would you recommend getting the COVID booster and or flu?
Not until you've seen a fetal heartbeat and it's had a couple of weeks to be there, so maybe 8 weeks.
Any foods I should avoid and any foods I should eat more of? I'm having my FET on Sunday.
Healthy, balanced diet, no alcohol, no marijuana, no gummies or edibles or anything like that. Relatively low sugar, relatively low cholesterol. Mediterranean diet is supposed to be the best. Fresh grains, fresh fruits, olive oil, low red meat, fish, that kind of thing.
Dr. V, 45 years old, AMH1.
45 years old?
Yeah. AMH1, 15ER, last 2 years, 15 embryos, all aneuploid. Any suggestions?
Ooh. At 45, your chances of having euploid embryos is extremely low. You're probably looking at roughly about a 95% chance, 90 to 95% chance that your embryos will be abnormal. So literally out of those 15, you probably haven't even gotten to enough yet to get one normal. You would need 20 to hopefully find one. I mean, I don't know. How many embryos did she say she'd done? How many retrievals, I mean?
15 embryos, all aneuploid.
But she didn't say how many retrievals.
15ER, last 2 years, 15 embryos, no, all aneuploid.
5 egg retrievals. I mean, respectfully, I would tell you it's time to do donor. If you still want to try on your own, I would do the delayed trigger to retrieval time. That's pretty much the only thing you can do. Keep your dosages of medications low.
What additional testing would you order before proceeding with IVF? Had labs for thyroid, LH, estrogen, CBC.
I think she asked us that one. Yeah. Or we answered it. Yeah. We're done? Mm-hmm. Perfect. Sorry for the glitches. We're going to find a solution to Yellow Duck. Hope you guys have a great evening. Thank you for joining us on Fertility Fact or Fiction. Use your testosterone priming if you are a poor responder or low ovarian reserve. It will double your chances, apparently. Have a great night, guys. See you next week on Fertility Fact or Fiction.